Concepts of Oncology, a channel exclusively for learning about cancers. Subscribe for new videos every week. Breast cancer case study number 2. A 55-year-old lady presented in OPD with painless lump left breast since last 1.5 years. No other specific complaints present. Patient attained menopause around 5 years back. On examination, there is a 5 by 5 centimeters lump with lobulated surface. Mobile, firm, not fixed to skin. There is no significant lymphadenopathy on ipsilateral axilla, supraclavicular fossa or contralateral axilla. So, this is a case of an elderly postmenopausal lady with a breast lump. In postmenopausal age group, any breast lump must be considered breast malignancy, unless proven otherwise. So, just by history our first DD would be breast malignancy. On examination 5 cm lump suggests T2 disease. Important point to note is lobulated surface. This is an important hint. Lobulation means smooth surfaces with scalloping contour due to shallow crevices. This lobulation is not a feature of breast cancer. So this is one point here which is not in favor of breast cancer. No lymphadenopathy, so it is N0. What is the first step in management? Breast ultrasound, breast X-ray mammography, breast MRI, PET scan. Let us start by excluding. PET scan is not an initial investigation of choice. It is usually done in biopsy-proven breast cancer for staging, particularly in locally advanced disease. Breast MRI is usually indicated in high-risk young women, for screening and before proceeding with BCS. Both ultrasound and mammography can be done, but more primary investigation in elderly women with breast lump is mammogram. X-ray mammogram shows well-defined lesion with perilesional halo. Rest parenchyma is normal. An FNAC was done which shows fibroepithelial tissue with hypercellular stroma, suspicious of fibroadenoma. Well-defined lesion is against breast cancer. Breast cancer due to invasive nature has ill-defined border. FNAC suggests fibroadenoma, but point to note is that this is not a typical age of having fibroadenoma, as patient developed lump in last 1.5 years. So here we have a condition which can mimic fibroadenoma on FNAC. What is the next step? Excision, core cut biopsy, follow-up, simple mastectomy. Since this is not typical age for developing fibroadenoma, so we need to confirm this finding by biopsy. As tumor is 5 cm, so core cut biopsy is better. Follow-up is not a good option due to age, as this age is a high risk factor for malignancy, and definite exclusion of malignancy can be done only by biopsy. We must not proceed with surgery just on basis of FNA, as this is not a typical age for fibroadenoma. This should raise suspicion. Core cut biopsy was done which shows malignant phyllodes tumor. Breast ratio was adequate. Metastatic workup was normal. Malignant phyllodes tumor can mimic fibroadenoma on FNAC, hence FNA cannot differentiate between them. Only biopsy can. Phyllodes can occur in any age group but mostly in 40s and 50s. It is well defined on mammogram and has perilesional halo due to compression of surrounding tissue. What is the next step? Simple mastectomy, modified radical mastectomy, wide local excision, neoadjuvant chemotherapy to decrease tumor size for better cosmesis. Malignant phyllodes is usually treated with either wide local excision or commonly mastectomy, as residual breast tissue after taking circumferential margin is not much. Modified radical mastectomy is mastectomy with level 1 and 2 axillary dissection. However, phyllodes tumor usually does not metastasize to nodes, so in N0 case prophylactic node dissection is not indicated. Tumor is resectable, hence there is no role of neoadjuvant chemotherapy, plus phyllodes are not chemosensitive. Here, either wide local excision or mastectomy can be done. Choice among both can be decided by tumor breast ratio. Poor tumor breast ratio means tumor is large as compared to size of breast. Hence cosmesis after wide local excision will be poor. Here tumor breast ratio is adequate means breast size is large. Hence even after taking margin of excision sufficient breast tissue can be preserved for adequate cosmesis. Patient underwent wide local excision and tumor was sent for histopathology. Lateral margin of tumor was positive. What is next step? Re-excision of lateral parenchymal tissue. Mastectomy, radiation, follow-up for any nodule and excision if recurrence comes. Since we know exactly the margins which was positive plus lateral part has more tissue than medial part, so re-excision of lateral margin can be done. But what if breast tissue was rotated for reconstruction after primary surgery? So here lateral margin has shifted due to reconstruction, hence difficult to remove lateral margin exactly, so better option would be mastectomy. Concepts of Oncology, a channel exclusively for learning about cancers. Subscribe for new videos every week.